Well, welcome to our neuroendocrine cancer patient education forum. So we were here 2 years ago. I'm Meredith Cummins and I'm the CEO for Neuroendocrine Cancer Australia. So lovely to see you here, and hopefully you get lots out of this evening. So we've got quite a few speakers. We've got a couple that are still in transit, but we can either do a song and a dance or whatever until they come. But I just first want to acknowledge the traditional owners of the Meanjin land, the land on which we're meeting here tonight, and also to pay my respect or our respects to elders past, present and emerging, and also to extend our respect to any Aboriginal or Torres Strait Islander people who are present here tonight. So our first speaker tonight is Associate Professor David Wyld. And David is the Director of Medical Oncology at Royal Brisbane and Women's Hospital. He has a long-standing clinical and research interest in neuroendocrine cancers, having established the neuroendocrine tumour service at Royal Brisbane and Women's Hospital, including development of the PRRT luteate service in 2008. He's currently the Australian co-chair of the Commonwealth Neuroendocrine Tumour Research Group and a member of the COSA Neuroendocrine Tumour Group Executive Committee. He is also the co-founder and current co-chair of the Queensland Collaborative for Cancer Survivorship. So I'd like to welcome David up. That works. Lovely.
Thanks, Meredith. So we're sort of starting off not quite with some of the clinical things, but a little bit of, I guess, an area that Meredith asked me to talk about, because these are two studies that are about to open around the country in neuroendocrine tumours. And I guess there's a lot of enthusiasm about them because they're collaborative across multiple of the major NET centres across the country. And for once, we've actually been able to get NH and MRC funding to support them. Maybe not. So the first one is the AUSNET trial, and I'm not sure if people have probably heard a little bit about this through Neuroendocrine Cancer Australia, but it's essentially a nurse-enabled shared care model to address unmet needs of individuals with neuroendocrine tumours. So I guess in a survivorship setting, there's a lot of discussion going on about different models, and one of those is shared care and how this can be done better between hospitals and general practitioners and other allied health practitioners. And to some degree, it's a little bit what is done sometimes very well and sometimes not so well, but more formalising that. This is a slide from Michael Jefford, who's a medical oncologist in Melbourne who runs the Australian Cancer Survivorship Centre. And he and John Emery, whose name will come up, who's an academic GP, have done a lot of work in shared care and published a couple of trials in prostate cancer and colorectal cancer. And so that survivorship centre have come up with some recommendations, which are clearly detailed. And I guess it's always the question of, well, what can you do in practice that actually improves the situation? Because there's a lot of barriers on all sides about trying to make this work well. And so I'll show in a minute, but there are a few projects going on around the country, and one in breast cancer that's already finished. And so there was enthusiasm using that sort of knowledge and models to do something in neuroendocrine cancer. And so there was using those people's knowledge and then the enthusiasm of NET centres around the country and Neuroendocrine Cancer Australia sponsoring things. Fortunately, we're very successful, very happy to get a large MRFF grant to do this project. So it's a collaborative project between the 5 major neuroendocrine centres around the country, Flinders University, which was where Ray Chan, the nurse who's helped coordinate a lot of these projects, had moved to from Brisbane. And so it's an ambitious study. It's looking at 500 people with neuroendocrine tumours across those 5 sites. And I guess the aim is simple in a sentence, but it may be a little bit more complex than that I'll mention in a minute. So I guess the advertising part of all of this is, well, who is this going to look at? And this is a practical type study. Some of the other studies are for people who've had potentially curative treatment, have had surgery and chemotherapy and then are in follow-up. Obviously, our circumstances is quite different to that, with a lot of people who are living with neuroendocrine tumour, not after having definitive treatment. So it's a pretty pragmatic design. It's basically including most people with low-grade neuroendocrine tumours at whatever stage of their disease. And really the exclusions are not, they're done to try and, I guess, make the cohort a little bit more standardised. So not doing small cell lung cancer or large cell neuroendocrine lung cancer, although low-grade neuroendocrine cancers of the lung would be included, and not including pheochromocytoma and paraganglioma, just because of their unique, I guess, features, particularly needing endocrinology input if they are hormonally active. So what's happening in practice? Hopefully reasonably soon, then all of the sites around Australia will be up and running, and the aim is to have an experienced neuroendocrine nurse, hopefully the cancer care coordinator in most centres, doing dedicated time for this study. The idea is we'll talk to people who are potentially eligible, and then those who are interested essentially randomised to either continuing normal care or having this additional, I guess, shared care model. The idea being that that nurse will then spend a good hour or so with the patient at some point during their treatment and really go through a number of issues. There will be a checklist of the type of things that we'll cover and look at what's important for that individual patient. And also liaise with the clinicians who are managing that patient's care, so what they feel that is important that the GP should know. Now, ideally, all of this is in letters, but obviously sometimes those things are a bit hard to explain, the complexities in a hospital letter, and we know that not everybody sends letters every time, and probably not everybody reads the letters that we send if they're too long either. And then there'll be a care plan that's devised for that particular patient, a little bit about treatment and I guess what sort of follow-up and imaging and timing of things like that. Again, it is a bit more difficult than, say, a colorectal cancer follow-up patient where you have your scans at 12 months, you have blood tests at a certain time point, you have a colonoscopy at 2 years. It's all very clear-cut, whereas in this it's going to be quite individualised. This will be the more challenging bit to some degree, is that ideally there will be a case conference with that individual's general practitioner, potentially with the practice nurse dialed in as well, and going through that detail and I guess explaining the patient's circumstances, what's required, potential issues that might come up, and also what sort of things it would be useful for the GP to assist with. Obviously, GPs are busy, don't always run to time either, so scheduling things will be the challenge of the team who are going to be helping to do that. I guess the other big challenge is a percentage of our patients don't have regular GPs, or they are in a GP practice where they see a different GP, and I think those are going to be the challenge of how we can try and ensure that those people are included in the study. And there will be some agreement in terms of follow-up. Obviously, this will vary from patient to patient depending on what sort of treatment they're having, or in particular how far away they are from the centre. So diagrammatically, it's fairly straightforward. You're having that more detailed conversation with the nurse, and that nurse is really representative of the team managing the patient, and then coming up with a plan, interacting with the GP, and then having a sort of a shared understanding of what roles each team would be doing. This slide does say that there wouldn't be any rapid access pathway back to the system, but I don't think in practice that's really correct in this situation, because most sites, the major sites, have a NET cancer care coordinator, which is either full-time, part-time, or shared with a different tumour type. And as you know, those people are usually pretty readily accessible. It may not be immediately, but they'll get back to you fairly quickly. So I think there's already a relatively good way of getting back into the system, but that may be enhanced by this, but it hopefully will allow the GPs a way of interacting better with the managing team if need be and want to talk about a patient issue. So that was, I said, there's a similar model happening. The breast cancer study's already completed recruitment, which was, I guess, the model for where this idea came from. And then there are a couple of other studies. But again, the difference is that last bit, at 5 years return care back to the GP, which is obviously different in this. And so I think there will be different learnings about ongoing shared care in this trial compared to the other study. So as I said, it is different in that way. The other big difference, which I think even those who wrote the protocol for this haven't quite got their head around, is that PRRT is given in the major capital cities and our patients come from all over the states. And so we have a lot of patients who are a long way away from Brisbane. So particularly we will be recruiting people who are having PRRT, because that's the ideal patient group who we need to let their GP and other people closer to home know what they should expect and what's unexpected and how to manage or who to talk to. So that's going to be an interesting issue, because that means these patients often have three teams. They have the GP, they have the NET centre, and they have an oncology service somewhere else. And we have done some work looking at the interaction between NET centres and regional oncologists through a different group. And some regional oncologists are more in Canada than here, but a bit in Australia and New South Wales. Some are very comfortable at looking after things and others are much less comfortable. And so this model doesn't really take into account their part in the whole take-up. And we did discuss that at length, and I think it was felt that it will sort of evolve as the trial goes on. It was just too hard to sort of try and devise something that had somebody in Cairns with a medical oncologist versus a private oncologist in Townsville versus people in Brisbane. So they're the sites, as you would expect. So the lutate therapy, the radioisotope therapy, sorry. So the major sites. So I think there's a lot of enthusiasm for the study. And obviously the central team includes the Neuroendocrine Cancer Australian team, plus people at Flinders who are doing the nuts and bolts for the study. As I said, as well as the neuroendocrine management teams, Michael Jefford has a huge amount of experience in this area. And John Emery is the GP who's been involved in a lot of these studies. So we're using a lot of their experience in similar areas. So I'll change tack completely. So the AUSNET study will be up and running, certainly from our point of view, hopefully in the next few months, and probably similar across the country. And we're hoping Beck, who's our NET cancer care coordinator, will be able to do that part of extend her role to do that role in the study as well. So this is another study that's coming, slightly or completely different in a way. This is the STOPNET study, which you may or may not have heard of as well. This is something that Matt Burge from our unit has been championing. We came up with this concept, I think 2018, so it's a long time ago. And it's been through various iterations to the point where it's also now going to be up and running around the country, sponsored through the AGITG trials group. So I'm going to mention it's specifically around patients who are starting their first cycle of lutate or PRRT. And the background to this is really that we all know somatostatin analogues are used routinely in patients with neuroendocrine tumours, and we've got good evidence that they're beneficial both in controlling carcinoid syndrome symptoms but also in tumour growth control. And a lot of patients will be on these agents for many years. But, as Matt would always point out, do they really need them all the time? And some patients do have side effects, obviously with their inconvenience and expense of having to have a monthly injection. Not too many people are comfortable giving the injection themselves, so it does mean going to a general practice or a hospital, the expense and time for all of that. Now, obviously, these are good drugs, so we know that in practice, a lot of people should be on these long term. If you've got carcinoid syndrome symptoms, they are the ideal way of controlling symptoms. And I think when Matt, in his very enthusiastic phase, said, well, if you've got no symptoms, maybe you don't need to continue. But I think from a patient and a clinician's point of view, nobody was very enthusiastic to be stopping SSAs if you've got proven carcinoid syndrome. I guess there are a group of patients who, particularly maybe pancreatic neuroendocrine tumours that are higher grade, they have a trial of somatostatin analogues, but only for a few months. It doesn't work, and I think most people would stop them in that setting. But there is a group of individuals who've been on somatostatin analogues for a while, but at some point their tumour is progressing and it gets to the point where a decision is made that lutate or PRRT is indicated. And I guess that was the group that we would sit in our NET meeting, and Matt would say, do we really need to continue them, particularly if they're having PRRT and they get a very good response from their tumour? And you're hoping that has a reasonably good duration of response. And the answer is we don't really know the answer. And what happens in practice in those people who don't have carcinoid syndrome, who've had a good response, is that it's an individual decision, and some people continue, a lot of people continue, but some people go, I just really don't want to have these injections if I don't have to have them for a while. So there's a bit of science, but there's a lot of just general judgment. And it'd be nice to know the right answer, because if you could say you've had a good response to PRRT, we're hoping that nothing changes for the next few years and you could be off the SSAs, always potential to start them down the track. That would be a good outcome for patients. So that's the background to this study, that if you're in that patient group where you don't need it for carcinoid syndrome, the tumour is progressing to the point where PRRT is indicated, then there's this uncertainty. Now, it could be that neuroendocrine tumours, slow growing, are different to other cancers where we would normally stop a treatment if it's not working. If chemotherapy is not working, we don't continue it. But maybe the paradigm's different in such a slow growing tumour and the different biology. And I guess we know in prostate cancer we often do continue hormonal therapy, even if that's not the only treatment. There are other things on top of that. In the PRRT studies, patients did continue octreotide or lanreotide, but that was because the initial study, you had to have carcinoid syndrome to be included in it. But also, they didn't want to answer two questions at once. You were trying to prove if PRRT worked. And there's a couple of different pieces of evidence, one that suggests maybe you do better staying on it, and then one saying you probably don't do any better staying on, but they're small individual centres, so nobody really knows the answer. So this is a very pragmatic trial of having PRRT in that situation, some people continuing and some not continuing, and everything else is the same. Now, there's been a lot of discussion, as some people in the room would know, about how to do this, and this is the final version of different options that were put around about who would be reasonable to offer this to. And what are you looking for? Well, they're looking for to make sure that there's no difference in how well the PRRT works. That's the main endpoint for looking at how long the disease remains stable after that time, to make sure there's no difference. But also looking at how acceptable this is to individuals and whether this is something that's reasonable to do. And then lots of quality of life and other measures for everybody involved in the study. So I'll skip over that. So as I mentioned, there are certainly people who you wouldn't offer this to. It's only going to be in select group. And then for those people where they're sort of borderline for the normal PRRT requirements, then you wouldn't do it in that group either. Not because you don't think it's going to be as valuable. It may still work in that group, but it may just, with a small group, a small study, it may bias one group over the other in terms of outcome, and that might make it hard to interpret the results. From an individual patient's point of view, all the treatment will be the same, the PET scanning will be the same, but if you're on the study, there will be more regular CT scans. Now, we're fortunate in Australia, we have such good access to PET scans that we don't do CT scans quite as often. But in a study like this, you really need regular CTs at a certain time point so that you can actually accurately measure how long it is while the disease is stable before issues arise. So that would be the main issue from a patient point of view. There will be patient questionnaires in terms of quality of life and other things there. So again, this will be done in the 5 major centres around Australia. Unfortunately, New Zealand couldn't be involved because they're only licensed to have octreotide, I don't think they have lanreotide, I've got to remember now. And it's only licensed for carcinoid syndrome in New Zealand. So even if patients are getting it without carcinoid syndrome, why a little white lie, technically they don't fulfil the trial criteria. So it was just not possible for them to do it. What has been a major thing was that the Canadian group, who, when Matt presented this in 2018 to our combined research group, were pretty lukewarm on his original concept, or very lukewarm, didn't make it to the afternoon discussion. But with the rejig of it and with more of their sites now doing PRRT, I think when it was first presented, there was only limited sites. They have now really been quite enthusiastic about coming on board and have drummed up enough money within Canada that they will able to recruit, which has actually allowed the study to have a larger patient enrolment. And the other factor that will be interesting in this study is that it's going to, as we said, there's a lot of patients who are going to live outside of the major centres. So there'll be a teletrial model. So for once patients have finished their PRRT, they can be followed up largely in their normal centre with their normal oncologist in a regional site as part and still part of the trial. This is through the Queensland Regional Clinical Trial Centre. It's a bit of an experiment for AGITG because what this is doing is not going to every ethics committee across the state and setting it up. This is going, we've got a patient from Mackay, they're going to get that going in that period while the patient's having PRRT. So they only set up sites that have got patients and not go through all the paperwork of trying to do it every hospital. It hasn't really been done for an AGITG trial before, so this is a little bit of a first to see how well it works, but obviously has a lot of implications for potential research in the future when you're trying to recruit across the state. These are some of Matt's slides that I've used for a slightly different audience, but really from 2018, the first concept that was worked over by a lot of people, including the patient the patient liaison group within AGITG, and finally came up with it. And then money had to be found. So there was a fundraising to actually get a pilot study going, and then a few grants, and then finally the MRFF grant. So it's taken a long time. I think this and the other study that's had an MRFF funding is a good reflection of the rare cancers funding, because when ControlNets, which was the previous large AGITG study looking at PRRT was unsuccessful in getting any grant funding over 4 years, and it was all done through philanthropic funding. So I think that's also a big tick to the sort of the network across the country. So unfortunately, Matt's not here. But fortunately for him, he's in Italy enjoying himself. But he's put a huge amount of work in to get this up and running. And it's great to have all of the Australians and Canadians on board. So we're hoping that this will sort of start also in the next few months. Obviously targeted to a slightly different patient group, a bit more selective. And I think patients and clinicians will have their own views about this, so maybe not everybody will be as enthusiastic about this study as the previous study, but I think it's a really important question as to whether really it is necessary to have those injections for that period after a successful treatment with lutate. And I'm going to finish off there. That was my brief, and hand over to Mark.
Thank you very much, David. Before I go any further, I just wanted to introduce a couple of people in the room. We've got up the back Steph Lindors. Can you stand up? Who is the Nursing Unit Manager at Nuclear Medicine at Royal Brisbane and Women's. And then we've got Beck Orford, who is our NET Cancer Nurse Coordinator. And up the front here, we've got Dana, who is one of our Neuroendocrine Cancer Australia nurses, and she lives here in Brisbane, but she also is on the telephone. So, please feel free to reach out to her at any time. But I just thought I would introduce some of the other personnel in the room. So our next speaker is going to be Dr. Mark Nalder, and he's currently a medical oncologist at Royal Brisbane and Women's Hospital here. He is also has private practice at Northwest Private Hospital in Everton Park. He has a strong interest in neuroendocrine tumours and is regularly involved in the neuroendocrine MDT at RBWH. He has a strong research interest, currently undertaking a PhD through the University of Queensland, and has previously published the results of PRRT lutate therapy in patients with neuroendocrine tumours in Queensland. So I gave Mark the task of talking about lung nets, of which he's diversified slightly.
There we go. Thanks, Meredith. It's a pleasure to present again. I'll just see whether it's working. So as Meredith said, my name is Mark Nalder. I'm a medical oncologist. I work at the Royal Brisbane as well as privately in Northwest Hospital. I was given the task of talking about lung nets today. Fortunately, as David or Dr. Wyld alluded to earlier, the management of lung nets is relatively straightforward. We take a lot of our information from lung nets based on the information from other tumour types, primarily gastric and also pancreatic. But I will go over it today. But for those of you who were here a couple of years ago, I gave a presentation about sort of the basics of neuroendocrine tumours, and we know that some of the terminology we use when you come into clinic can be confusing, and you want to know what stage, what's the Ki-67, what's mitotic rate, what are we talking about when we're talking to you. So for those of you a couple of years ago, this presentation will be somewhat familiar, and I've delved into those topics again because I know some of you in the room today may have a relatively new diagnosis of a neuroendocrine tumour, or for some of you in the room, it might be good to go over that information again. So I'll go over in about 15 minutes. Hopefully it'll clear up some confusion people may have about their particular tumour type or things we think about in medical oncology clinic, particularly when we're managing neuroendocrine tumours. So I'd just like to emphasise, again, all of you are unique. I'm going to talk today about how we manage neuroendocrine tumours in general, but just bearing in mind there's no one-size-fits-all approach with these tumour types. We rely very much on a multidisciplinary approach to managing these tumour types, and certainly medical oncologists with an interest in neuroendocrine tumours are appropriate, but we also rely heavily on consultations with our nuclear medicine colleagues, radiation oncologists, cardiologist as well in relation to some of the complications, also endocrinologist as well. For some of you who would have been here a couple of years ago, would have seen a very good presentation by Dr. Amanda Love, who has a special interest in this area and is also involved in the NET-MDT at the Royal Brisbane. But just keep that in mind when I'm talking tonight, that I'm talking in general, and there's no one-size-fits-all approach. So we'll talk about what neuroendocrine neoplasms are. I'll delve into lung neuroendocrine neoplasms. What is DIPNEC? For those of you who may have heard of that term, I'll quickly go over that because that can be associated with lung neuroendocrine tumours, treatment in the early stage, and also treatment in the metastatic setting, or those who have more advanced stages. I will go into lung nets in general, but there'll be some cross cover between lung nets, and also those of you who don't have lung nets may have gastrointestinal or pancreatic nets as well, because there's a lot of overlap in the management. So all neuroendocrine neoplasms are generally defined as either NETs or neuroendocrine carcinomas. Neuroendocrine carcinomas are typically very aggressive malignancies, usually known as large cell or small cell malignancies that usually require chemotherapy. They're very, very aggressive tumours that often progress quite quickly, whereas NETs, which is more what I'm going to be discussing today, probably what most of you have experienced in the room today, usually lower grade tumours that don't respond so well to chemotherapy, but fortunately we've got many other options for treatment as well. So there's a few things from a medical oncology perspective that we may think about, particularly when we're seeing someone for the first time, and I'll go over these things today because there's some of the terminology that I was talking about that can be confusing. These are often the important things that we think about. Where does the tumour, where did it start or originate? What is the grade or the Ki-67 of the tumour? What is the stage of the tumour? And then is the tumour functional, or does it secrete certain substances which may present themselves with symptoms such as carcinoid crisis or carcinoid or valvular heart disease, or many of the other things which can happen, which I'll go over shortly as well. We look at these things because they're important in terms of deciding not only treatment but also prognosis and what therapies we may use later on. So where did the tumour start or originate? So often there's a poor understanding in general about neuroendocrine malignancies, and the neuroendocrine system itself is made up of many nerves and gland cells, and these nerve or gland cells generally produce hormones and release these into the bloodstream, creating different effects. The most well-known is probably insulin, which regulates your blood sugar, but there's many other hormones in your body which are produced by these hormone or these nerve cells. And neuroendocrine neoplasms essentially arise in these nerve or gland cells, and that explains why some people have functional syndromes, because there can be overgrowth of those particular substances. So you may hear us talk a lot about what is the grade or the Ki-67 of a patient's tumour. This is important because, once again, it has both therapeutic implications but also important implications in terms of prognosis. So going from the top, grade 1 NETs, or grade 1 to grade 3 NETs are usually tumours that are well differentiated, whereas poorly differentiated tumours are those neuroendocrine carcinomas, which I talked about earlier. They're the very aggressive subtype, but I'll keep it to the top 3 there. So for the purposes of lung NETs, grade 1 tumours are essentially your typical lung carcinoids. You may have heard of that and then grade 2 tumours are atypical lung carcinoids when we're talking in the lung sphere. Those tumours have a low mitotic rate. That means that they're dividing very slowly when our pathologists look under the microscope, and they have a low Ki-67 percentage, which basically means the same thing. Intermediate grade NETs have a slightly higher mitotic rate, meaning they're dividing a little bit quicker. They have a higher Ki-67 percentage as well, and they tend to have a slightly more aggressive course than the grade 1 tumours. I'll talk about functional imaging with dotatate PET and also FDG PET later, and why this is important. But generally speaking, for our lower grade tumours, they're usually much more likely to express somatostatin, and we look for that in dotatate PETs, whereas the poorly differentiated tumours or the higher grade tumours are usually more FDG avid. So that may explain why we sometimes do we might do a dotatate PET, or in some cases we'll do an FDG PET, and essentially that's what we're looking for. You may also hear about TNM classification. This is standard across all cancer, well, most cancer tumour streams in terms of how we stage patients. So T stage is how big or how invasive the tumour has invaded. Generally smaller tumours or less invasive tumours are T1 or T2 tumours, whereas those larger tumours or more invasive tumours are T4 tumours. End stage is lymph nodes, meaning has the tumour moved into any of the surrounding glands around the tumour. They can go from either N1 to N3 depending on the amount of lymph nodes that are involved. And then metastasis is their tumour deposits outside or in other areas of the body, and that's generally M0 or M1. Now, we don't usually use this definition too much in neuroendocrine tumours. We use sometimes more in lung neuroendocrine tumours, particularly if we're thinking about surgery, but it's something to be aware of in case, your particular oncologist or GP are speaking about it. So what is the stage? Based on that staging before, we generally will stage tumours into stage 1 to stage 4. Stage 1 and 2 means that the tumour is just confined to that area. It hasn't spread to the lymph nodes or further afield. Stage 3 generally means it is involved in those glands, and then stage 4 means it's moved elsewhere in the body. And I mentioned earlier that neuroendocrine tumours can cause functional syndromes. The most commonly known to probably many of you in the room is the carcinoid syndrome. Around 20% of patients, particularly with small bowel nets, can experience the carcinoid syndrome, flushing, diarrhea, cardiac complications, which I think Dr. Lorcan's going to be speaking about shortly. Can all happen, and predominantly this is driven by a substance called serotonin, which can cause those symptoms. Majority is in those patients with small bowel nets, particularly those with liver metastases or cancer that's moved to the liver, but can also occur in lung nets as well, and rarely can occur in other neuroendocrine tumours as well. Can also, in terms of lung tumours, it can also secrete ACTH. Around 1 to 2% of lung neuroendocrine tumours will secrete ACTH, and that can cause something called Cushing's syndrome, which is where you can have rapid weight gain or problems with your blood sugar levels, thin skin, etc. And I mention this because many patients can present with these symptoms as their diagnosis. They don't, as up on the Neuroendocrine Society meeting here, often there's a big lag time between when patients first experience their symptoms and when they're finally diagnosed, but sometimes symptoms related to these can be what leads to someone's diagnosis. So what about lung neuroendocrine neoplasms? As I mentioned before, they're really classified into NETs and NECs, or neuroendocrine carcinomas. I'm not going to talk about neuroendocrine carcinomas because they're the higher grade tumours, but essentially lung neuroendocrine tumours are divided into typical and atypical lung neuroendocrine tumours. Typical lung tumours are the ones they're very low grade. They have a low mitotic count, meaning they're dividing quite slowly. They have a very low Ki67 score, whereas atypical lung nets have a higher Ki67, a higher grade. And those tumours are the ones that are much more likely to come back if they're surgically resected. So facts, so incidence of lung nets are around 1 to 1.5 per 100,000. This makes it a quite rare tumour type. Typical lung nets are 4 times as common as atypical, so much higher incidence in women than men. Unlike most lung cancers that we see, adenocarcinomas or those neuroendocrine carcinomas, there's no clear association with smoking as they're seen in those other tumours, or there's no clear association with environmental exposure. The average age of diagnosis for a typical lung net is 45, and in atypical it's 55. Carcinoid syndrome does occur, but it's rare in lung nets, and there's a 1 to 2% rate of Cushing syndrome, which I mentioned already. So what about imaging? So around 80% of typical lung nets express somatostatin receptors, which can be seen on dotatate PETs, and around 60% of atypical nets can be seen on dotatate PET as well. Higher grade tumours, as I mentioned earlier, are often better seen on FDG PET, but we do have sometimes an overlap where patients will have both dotatate avid and FDG avid lesions, and that's something we often discuss because that has therapeutic implications, and I believe Dr. Pattison's going to be talking about that later. So I won't go too much into this, but essentially, as you can see on the, I would have a pointer here, but it's not working. You can see a dotatate PET and an FDG PET. This patient had a very dotatate avid lung lesion, but as you can see, there's absolutely no activity on the FDG PET below. This patient had a typical lung carcinoid. So that's kind of the different modality that we see. So what is diffuse idiopathic pulmonary neuroendocrine cell hyperplasia, except for a lot of words, known as DIPNEC? So a small proportion of lung nets can arise in patients with DIPNEC. It's a rare condition, but it's caused by an overgrowth of neuroendocrine cells in the lining of the airways of the lungs. It can invade locally to cause these multiple tumulets and a lot of airway inflammation. And many patients who have this condition get symptoms such as shortness of breath or cough or wheeze, or they may be completely asymptomatic when they're diagnosed. This just comes up on a normal CT. But it's important to remember many patients with DIPNEC don't develop neuroendocrine tumours as well. There's an association, but not all patients with it do develop it, and although there's some treatment options such as SSAs, which have been shown to decrease the wheeze and the shortness of breath from this, you can also use inhalers. There's really not much evidence given the rarity of this condition, but there is some evidence that SSAs and also inhalers can help those symptoms. So treatment of early stage lung nets, surgery is really the optimal curative option in early stage lung nets. Those with stage 1 to 3, we would generally recommend surgery if we can. Relapse rates are much higher in those with atypical lung nets. Generally speaking, those with typical lung nets, the relapse rates after surgery are less than 15%, where they get up to around 30% with atypical lung nets. The important thing to know, though, there's no evidence that adjuvant therapy, that means therapy after surgery, whether it be somatostatin analogues or chemotherapy, reduces the risk of resected nets coming back, and that's across all tumour types. So there's no evidence that giving somatostatin analogues or chemotherapy reduces the risk, so that's not something that we do in practice. Occasionally radiation is used if we can't surgically resect early stage nets, and sometimes that's given with chemotherapy, particularly for those who may have higher grade lung nets, but that's something we'll discuss in a specialist multidisciplinary meeting. So in terms of unresectable or metastatic lung nets, so unfortunately the rarity of this tumour type, and as Dr. Wyld alluded to, it's incredibly hard to run large trials to provide evidence, particularly in this tumour type or in any NETs tumour type. So it's great to see a couple more trials coming up. There was a trial called the SPINET trial, which was looking at somatostatin analogues in lung nets versus not giving that, and unfortunately that closed early due to poor recruitment. So a lot of the data that we have for lung nets is taken from gastrointestinal or pancreatic nets, which I mentioned earlier, which I'll go over quickly. So somatostatin analogues for patients with slow-growing typical or atypical lung nets. International guidelines do recommend considering commencing SSAs. This recommendation, as I mentioned, is largely based on evidence that we have in the gastrointestinal or pancreatic neuroendocrine tumours based on those two large studies there. That SPINET study was the one I mentioned just before, but that failed to recruit. But in Australia, it's important to know that PBS reimbursement for lung neuroendocrine tumours is only available or limited to those who have a functional carcinoid syndrome. Unfortunately, there's no PBS listing for somatus octreotide or lenalidomide for those who don't have a functional syndrome in Australia at this point in time. So what about chemotherapy? It has a limited role in most lung nets. It's primarily used in those with higher grade or more aggressive tumour types, particularly potentially after failure of SSAs or potentially lutetium. Commonly used as cisplatin-based chemotherapy or platinum-based chemotherapy, which is what we use in those higher-grade neuroendocrine carcinomas, which I mentioned earlier. And sometimes we use chemotherapy in conjunction with lutate, but it's more common in other types of neuroendocrine tumours than in lung ones. So what about targeted therapies? Sunitinib and everolimus are approved in pancreatic nets only on the PBS in Australia. These drugs work by targeting a mechanism that tumours have to create new blood vessels or the replication cycle, and it does have activity in lung nets. There was a trial called the RADIANT-4 trial, which did show that it does work in lung nets, but it's not PBS reimbursed, and it can be quite toxic. There's some unique side effects to these two medications, and it can be quite tough to tolerate. So it is a potential option, but it's not available in the PBS, and if it's something you'd be interested in, you would have to self-fund. It can be quite expensive. I won't go too much into lutetium treatment as Dr. Pattison's arrived and he'll be talking about that later. Just know that in lung neuroendocrine tumours, we do use it from time to time, particularly after failure of SSAs. The NETA-1 trial, which is the basis of why we use lutate, didn't include patients with lung NETs. We do have case series reports of activity in lung neuroendocrine tumours, and we do recommend it for those patients who have essentially dotatate avid disease if they're appropriate and discussed in the neuroendocrine meeting, but just know that the evidence for that isn't as strong as what we have in other types of NETs. I did put this in last time. We know that in Queensland the treatment, the overall survival, it's about 61 months from first dose of lutetium. This is for all patients with neuroendocrine tumours. I wasn't sure how I was going for time today, so I might just skip over that quickly. And that's really about it. So it's a bit of a chef's tour of the terminology of neuroendocrine tumours. I did throw some lung NETs in there as well, but happy to answer any questions people may have later on in the session. Okay, thank you.
Do you want to load up your...
Yeah, sounds good.
So we will have Q&A at the end, so hang on to any questions that you've got so that we can do that. So our next speaker is Dr. Lorcan Ruan, is that right?
Yeah, that's pretty good.
And he's a fellow in echocardiography at the Prince Charles Hospital. So he's a cardiologist with a special interest in cardio-oncology and carcinoid heart disease, and he's currently undertaking a subspecialty fellowship in echocardiography at the Prince Charles Hospital, and prior to this undertook physician and cardiology training at the Royal Brisbane. And Lorcan's research work aims to improve our understanding of the effect of cancer and its treatment on the heart. So I'll hand over to you.
Great, thank you. Great, thanks so much, Meredith, and thanks for giving me the opportunity to talk this evening. So my topic is carcinoid heart disease. I'm going to cover 4 broad areas within this. The first thing I'm going to talk about is why exactly is carcinoid heart disease important? Why are we dedicating a whole session to this this evening? I'm then also going to talk about exactly what is it, how we diagnose it, and how do we treat it. So firstly, why is carcinoid heart disease important? Well, the first thing to say here is that it is common, relatively common. So the majority of patients with a neuroendocrine tumour certainly don't get carcinoid heart disease, but it is still a significant minority. To properly understand, I think, the rates of carcinoid heart disease and also the actual reasons why people get it, it's worth just reviewing a couple of basics as well about neuroendocrine tumour, some of which has already been touched on. So you may know that many neuroendocrine tumours are found in the intestines, the pancreas, or the general gut area, and they have the tendency to release a number of hormones and other substances that can exert effects on other organs in the body and cause symptoms. Some tumours are just localised to the gut. They're not found anywhere else. And if that's the case, then those substances that are released from the tumour can actually be inactivated by the liver before going on and causing harm. But in a significant proportion of patients, they actually have metastatic neuroendocrine tumours, so the tumour cells are found beyond the gut. And if those tumours are secreting those substances, hormones, molecules, then those patients are at risk of developing carcinoid syndrome, as Mark just discussed. And still, it's the minority of patients get carcinoid syndrome, and it's that group of patients that are at risk of developing carcinoid heart disease. And the more recent data shows that about 15 to 35% of patients with carcinoid syndrome can get carcinoid heart disease. The other main reason why this is such an important topic is that it can cause significant symptoms and impact on the patient's quality of life, and as well as their survival. Now, decades ago, the survival of a patient with carcinoid heart disease was quite poor. It was as low as less than 1.5 years. But the good news is that that has certainly improved. And it's improved for a couple of reasons. The first, the main reason for that is that we can treat it much more effectively today. And when I say treat it, I mean treat the actual heart disease, but we're also improving our treatments of neuroendocrine tumours in general. So the survival has significantly improved today. One recent study found that the average survival of a carcinoid heart disease patient is now in the order of 8 years. It may even be more now. But still, there is a significant discrepancy in the survival of patients that have a neuroendocrine tumour and have carcinoid heart disease and those who don't have carcinoid heart disease. So what is carcinoid heart disease? What's actually affected here? What's the mechanism? Why is this occurring? And what are the symptoms that a patient can experience? So as we may know, the heart sits in the middle of our chest, and it's essentially a pump. Used blood returns from the rest of the body to the right-hand side of the heart, gets pumped to the lungs where it receives oxygen, goes back to the left side of the heart, gets pumped out to the rest of our body, keep our organs working. Now, in carcinoid heart disease, it's the right-hand side of the heart that's usually affected, and specifically the heart valves. The pumping of blood in the heart occurs in a very efficient and very timed way. So firstly, the heart chambers or the ventricles fill with blood and then they squeeze. And that occurs in 2 distinct cycles. Now, the heart valves are very important for determining the effectiveness of those 2 cycles. So firstly, on the right side of the heart, that first valve there, which is called the tricuspid valve, opens and that right ventricle fills with blood. When it's filled enough, then that tricuspid valve closes, the right ventricle then squeezes, and because that valve remains closed, blood goes forward only to the lungs. What happens in carcinoid heart disease is that those valves, and particularly that tricuspid valve, becomes very short and stiff, and it doesn't close properly. So when that right ventricle squeezes, not only do you have blood going forward, but you also have blood going backwards. And the end result is that you have less blood going to the lungs and the rest of your body, and congestion in the right side of the heart and the liver. So why exactly does this occur? What's the mechanism? Well, we've already talked about carcinoid syndrome and how it's associated with increased levels of many different substances which can cause harmful effects. One key example is serotonin. Now, this is something that is very important in the normal functioning of our body. It plays a number of different roles. One of those roles is that it helps to lay down sort of fibrous tissue or scarring for wound healing, for instance, after you cut yourself on your skin. Now, that's a positive thing, but it may not be a useful thing in other circumstances or in other organs. And the heart actually has a lot of serotonin receptors. And usually they're very flexible and mobile. They're quite elastic. So when you have high levels of serotonin, for instance, in the setting of carcinoid syndrome from a neuroendocrine tumour, there is a risk of all that extra serotonin causing fibrous scarring of the heart valves. The result is those stiff and short valves that I showed. What are the symptoms that the patient should look out for? So there's 3 main ones here. The first is fatigue. That occurs due to that reduced blood flow from the heart and oxygen to the organs. Breathlessness is a very common one, and that occurs because of that reduced blood flow to the lungs. And leg and abdominal swelling is also quite common. That occurs because of that backwards blood flow and that congestion from the right heart failure. Now, a large proportion actually may not have many symptoms, depending on the stage of their condition. The right heart is actually quite good at adapting to the leaky valve and the extra fluid. That could be a good thing, but it also does mean that late diagnosis is common. It can also be quite difficult to distinguish these symptoms from a patient that just has very advanced neuroendocrine tumour. There's a few symptoms on that poster there: racing heart, abdominal pain, and fatigue, which all could be due to the neuroendocrine tumour itself or the carcinoid heart disease. Diagnosis. The main way we make the diagnosis is with something called echocardiography or heart ultrasound. And I'm going to talk briefly about this. I'm also going to talk about this concept of screening as well, which I'll explain. So echocardiography or heart ultrasound is the main tool we use. It's simple, it's non-invasive, and it gives us a lot of information that we require. Tells us about the pumping function of both sides of the heart. Tells us about the structure of the valve. Not sure how well this projects, but that image on the top right of the screen there is a normal looking tricuspid valve, two quite mobile leaflets. And then on the bottom right, we have one that's affected by carcinoid heart disease. It's meant to be exactly the same valve, but those leaflets there are quite short and restricted in their movement. The echocardiogram also tells us about the functioning of these valves, and it does that by displaying this red and blue colour, which signifies blood flow. Red colour signifying forward flowing blood through the valve, and blue is the blood flow going backwards. So you can see there on that valve on the right-hand side on the left-hand side of the screen there, there's a lot of blue flow. It's very affected by the carcinoid changes. So one of the big questions is, when do we test? When do we perform echocardiography? There's a couple of different methods to doing this, and one potential thing we can do is sort of routine, indiscriminate echocardiograms at routine intervals in any patient, regardless of their symptom status. Or we could only do the echocardiogram when the patient, when we are suspicious that this patient may have carcinoid heart disease. There's pros and cons for both approaches, and there are some theoretical advantages to screening for a particular disease. It really depends, though, on if identifying a disease at its early stage is going to allow us the opportunity to change management and prevent progression. And there's not a huge amount of evidence that in carcinoid heart disease that will happen. Okay, so and the other thing is that there's really only one effective treatment for carcinoid heart disease, which I'm going to talk about, and we only perform it when the patient is symptomatic and when their valve is severely affected. So going hunting for it at an earlier stage may not actually change our management in the long run. And this is the approach that's generally reflected in the recommendations and guidelines around the world, and I think it's generally practiced, at least here in Queensland. This is one such recommendation that says echocardiography should be performed in all patients with carcinoid syndrome and a high suspicion of carcinoid heart disease based on clinical features. So in other words, we look to perform echocardiograms if we are suspicious. And that, I guess, also illustrates the importance of the patient in this process as well, because we really have to rely on your reports when we review you in clinic. Lastly, treatment. So like a lot of things in medicine, there's two broad categories here. There's medications and surgery. With heart failure in general, we have a lot of really good medications. We call this heart failure therapy. Heart failure being a general term to describe the patient's heart when it's not pumping enough blood. And that can be due to a lot of different causes, including valve dysfunction like in carcinoid heart disease. The only issue is that a lot of the good heart failure medications we have are only good for the left side of the heart and problems with the heart muscle itself rather than the valves. So the role of the typical heart failure medications we have is actually quite limited in carcinoid heart disease. We do use a lot of diuretic therapy, though, to relieve that fluid congestion. That's medications like Lasix. We do have to balance that against the risk of dehydration, though, because the right heart is quite susceptible to dehydration. I think it's important to mention here somatostatin analog therapy, which is obviously the backbone of a lot of treatment for neuroendocrine tumour patients. The way this works is that it activates these somatostatin receptors on tumour cells and reduces the amount of things like serotonin being released. So it makes sense that perhaps this could treat carcinoid heart disease. There is some evidence that actively giving octreotide may reduce the progression of carcinoid heart disease, but it's hard to definitively say that that's the case. I think overall we could say that the improvements over the last few decades in the outcomes of carcinoid heart disease would be due to improvements in the treatment of neuroendocrine tumours in general, though. And there's certainly no evidence that it causes a regression of carcinoid heart disease. So once those valves are stiff and leaky, there's only one therapy really, and that is surgery. So surgical valve replacement is our main treatment for carcinoid heart disease. It's a big deal. This is open heart surgery. And just to give you a bit of an insight into what can be expected, you usually get seen at the surgical clinic at the Prince Charles Hospital, go on the waiting list, 2 to 3 hour surgery, a couple of days in ICU, week in hospital, and a recovery over a few weeks. It's obviously no small feat. Who actually gets surgery? So we perform surgery in those patients that have severe valve leakiness as well as symptoms or evidence of right heart pumping failure on the echocardiogram. It's important to note as well that we only want to put someone through the ordeal of surgery if we think their body's going to be able to cope with it and that they're going to be able to recover. We also wouldn't want to do it to someone that has a life expectancy that is already significantly impacted by another reason, such as a very advanced neuroendocrine tumour or any other disease, really. Some may ask, why not replace the valve earlier? Why not do this if we identify it at the mildly leaky stage or before it's really impacting on you? Well, again, the main reason is that we don't want to put someone through surgery unless we do really need to. And we'd only do it as well as if we had good evidence that in the long run, taking that approach improves the overall survival. The surgical risk itself is higher in carcinoid patients specifically. So decades ago, there was even a 1 in 5 chance of significant complications and even death during the surgery. But now that is significantly better. It's much, much lower because we've become much, much better at doing the surgery. But again, the surgical risk is a bit higher in patients with carcinoid syndrome compared to someone that was getting their valve replacement for another reason. And the good news is that the outcomes overall after surgery are really good now. So the clear majority of patients have a significant improvement in their symptoms and quality of life, and they have a significant improvement in their overall survival now. I mentioned earlier that average survival is now in the order of many years compared to what it was decades ago. I thought I'd just end my presentation as well with a bit of a case example, a real life case example from a patient in Queensland. I'm very thankful to for allowing me to talk about their story. So this patient was diagnosed with a neuroendocrine tumour at the age of 63. That was a few years ago now, I think back in about 2016 or 2017. They had involvement in their intestines as well as in the liver and bone. Initially they were going pretty good, minimal symptoms. They underwent a couple of courses of typical carcinoid treatment, somatostatin analogue therapy, lutate therapy. They had a couple of echocardiograms early on as well, and that's one of the videos from that echocardiogram. That's that tricuspid valve there. It's working well, essentially. No issue there. And then the patient had progression of their tumour in 2022. They experienced significant symptoms, abdominal pain, breathlessness, fatigue. They had a significant decrease in their exercise capacity. So they were previously pretty fit, but now are only able to walk up a couple of flights of stairs before getting very, very puffed. They had an echocardiogram which confirmed severe carcinoid heart disease. So their tricuspid valve was very leaky and their right heart was failing. Around this time as well, because they were they had progression of their tumour, they were planned for another round of lutate therapy. So there was a real need to stabilise the heart function as well in preparation for that, because there is a risk of decompensation. This is the pictures from the echocardiogram. You can see on the left of the screen that tricuspid valve there. One of the leaflets is actually still working pretty well, but the other one on the left is quite short and restricted, and their valve was very leaky. So they underwent tricuspid valve replacement surgery. It was a routine operation. Their heart rate did go quite slow in the days after, so they did get a pacemaker implanted. It was a difficult recovery over the next few weeks, a bit of chest discomfort from the wound, fair amount of fatigue, but they did go on and have the lutate therapy, which went well. This is the valve replacement on one of the more recent echocardiograms, and that's working really well. And overall, the patient now, over 12 months later, has had a significant improvement in the symptoms and quality of life. They went from only being able to walk a couple of flights of stairs now to being able to get back to walking 10 kilometres a day. And they've had stable neuroendocrine tumour status as well. I think I really like that case example because it also summarises a lot of the things I've talked about in the presentation. So some of the key points I'd like to leave you with are that carcinoid heart disease, as I said, it occurs in a minority of patients, but it's still a significant rate. It's a thing we should all be aware of. It does occur in patients usually with carcinoid syndrome. The symptoms include breathlessness, fatigue, and the diagnosis can be tricky, but surgery is today a very effective treatment. Thank you. Just get out. Just quit that.
Okay. So our next speaker is Associate Professor David Pattison, and David underwent dual specialty training in both endocrinology and nuclear medicine at Royal Melbourne Hospital, the Austin Hospital and Peter MacCallum Cancer Centre in Melbourne. He was appointed as staff specialist at Peter MacCallum Cancer Centre at the completion of his training and moved to Royal Brisbane in 2016, where he currently is are you still the Deputy Director? Or have you gone up further? Of the department, okay, of nuclear medicine and specialised PET services, and nuclear medicine lead for the Royal Brisbane Nucleotide Therapy Service. His research interests are at the intersection of nuclear medicine and endocrinology, neuroendocrine tumours and thyroid cancer and prostate cancer theranostics. So tonight he's going to update us on PRRT. Thank you.
Great, thank you. Thanks, Meredith, for the opportunity to speak to you tonight. And yeah, there've been a great couple of presentations I've seen beforehand, so there's a tough act to follow. I'll be talking about peptide receptor radionuclide therapy and a couple of updates. Well, a little bit of background about that, and then also a few updates about some recent trials and recent developments. So I'll be talking a bit of an introduction about NETs. Brief discussion about NET imaging, such as, when do we use the dotatate PET scans, when do we use FDG PET scans, a little bit about peptide receptor radionuclide therapy, so, which patients do we treat with lutate, what are some of the side effects and how is the treatment administered as a general overview, and then I'll be talking about some of the sort of next generation treatment options and some results from some trials overseas and also, where we're heading in Australia. So an overview to theranostics, this term's used a lot, and the best description of it that I can find is it's when you can predict the response of a therapy using a diagnostic test. And it's a really important method of being able to provide personalised medicine. I don't know if you can see a cursor up there. Yeah, you can. And so, so the idea, this is the diagnostic test, for example, let's say dotatate, so it's an imaging compound. You can do a scan and you can see if the disease is present and if it's taking up enough of the tracer to be treated. If so, we can then proceed and use a different compound. So rather than gallium dotatate, which is a PET imaging tracer, we would then use lutetium dotatate, which is that therapeutic version where it delivers all of its radiation within about 1 millimetre of where it binds to the tumours. And so that's, as we'll hear, and it's been alluded to already, that's an effective treatment. Here we are, there's the mouse. And we can give that, and then we can use that same diagnostic test, so the dotatate PET scan again, to follow up, see what the response is like. Hopefully it's favourable. But one of the key things is down the track, in a personalised fashion for that patient, if the disease comes back again, we can then go back and retreat and do the same process. So it's a really neat, personalised means of following progress and delivering therapy. Another one of the key elements of this approach is that if on that initial dotatate PET scan, if the target isn't being expressed, if we can't target that treatment, then it means we know up front and we can avoid a futile therapy, and it means there can be rational decisions made about what is a better treatment approach for that patient. So it's a really useful one to guide treatment if it's either positive or negative. A little bit about neuroendocrine tumours and the diffuse neuroendocrine system. So there are these endocrine or neuroendocrine cells right around the body, and this can determine some of the neuroendocrine tumour organs of origin. So we've heard from Mark already about the lung neuroendocrine tumours, but as we know, they also arise from within the pancreas, from the adrenal glands, such as pheochromocytomas, the small intestine quite commonly. This is what leads to carcinoid syndrome, as we've just heard in the last talk, and carcinoid heart disease. Rarely you can also get carcinoid syndrome with some other types, including lung carcinoids. And also more rarely in the bowel, but also, sometimes rarely in the cervix and ovary. And also, they can arise from the thyroid with medullary thyroid cancer. One of the key measures as well, though, is that for all of those different tumour types, the key marker that determines whether they can be treated with lutate or not is on the expression of those somatostatin receptors. So we don't sort of decide, we can definitely treat this or can't. It all comes down to those scans that can help determine the treatment. And in some cases, some types are more amenable to treatment than others, but at the end of the day, it's the PET scan that helps to guide that. There has been some significant, changes and evolution in the way that we can do this imaging, particularly over now really the last sort of 2 to 3 decades. And this is somatostatin receptor imaging. So imaging those receptors on the tumour cells. Previously, the older technology, which is now I've been giving this talk for a while, but that this is now 20 to 30 years ago, really, where we were using that more typically is the glyconotriotide scan. People used to talk about nuclear medicine, and they joke and call it unclear medicine, which it isn't particularly clear. I'm happy to say that, but nowadays there has been this evolution, and so we can get SPECT imaging, where you can see the distribution of those receptors in the body in 3 dimensions. And then when you confuse that with a low-dose CT scan, you get this SPECT CT. So it is better than what you could see here. But then, more recently with dotatate PET scans, you get much greater resolution on a PET camera. And so this, in fact, is the same patient imaged, with the older technology, but then the more current dotatate PET scan technology, and you can really see it's much greater resolution there. And those scans were actually only taken about a week apart in that patient. So when do we use the dotatate PET scan? Just broadly, it can be used for staging. So sometimes people will present with symptoms of a neuroendocrine tumour. It can be difficult to see where that's coming from. And this is particularly things like insulinoma. There's a couple of other tumours that may be in the pancreas, very hard to find. So the patient has clear symptoms. They have a diagnosis made already based on blood tests, and no other tests can find it. And in those sort of situations, so for localization, that can be a very effective means of identifying that. It can also be used for staging. When someone is known to have a tumour, they know that it's in one site, but you can make sure that it's not in other sites. For example, in planning for surgery, it can be used, as we've talked about already, for theranostics, where we're determining whether or not that patient's, we know that the tumour has spread, we know that they have symptoms and may potentially be eligible, and that's a test to determine if that's the right treatment for them. And then we can also use it in restaging. So after someone has had a treatment, which may be lutate treatment, it may be other treatments like chemotherapy, and we can then restage and see what's happened to the tumours, down the track. There are a couple of different, I won't spend too long on this slide, there's a couple of different traces that we can use in different settings for different neuroendocrine tumours. We can use something called, F-DOPA. This can be used in a particular kind of thyroid cancer, so medullary thyroid cancer. It can also be used in pheochromocytoma and paragangliomas. MIBG scan is similar to that, but it's an older technology. We have these are the somatostatin receptor analogues, which we've talked about already for gastroenteropancreatic nets. There is a tracer that can be used specifically for insulinoma. And of course, FDG PETs or sort of sugar PET scans, which help us we'll talk about now, but that's where we're looking at parts of the tumours that may be growing faster than other parts, tend to use more sugar. This is just a slide showing that, tumours that are a bit more aggressive are more likely to take up FDG, which is a second kind of a PET scan. And so it can be quite useful as a means of identifying sites of the tumour that are growing more quickly. We don't do FDG PET scans in everyone, but these are the main times when we may do an FDG PET scan. So it can be if the Ki-67 or the tumour grade, is higher, it suggests that tumour is perhaps more likely to be FDG avid or take up the tracer. If when the dotatate PET scan is done, if there's any sites that of suspected disease that aren't taking up the dotatate, then this can be done because it may well be that they're FDG avid instead, and potentially if it's confirmed to be a tumour site, biopsying that might potentially change the way the patient's treated. Sometimes if the tumour on the sample that's been taken by the initial tumour assessment, that might be low. It might only be sort of 1 or 2%. But if the behaviour of the tumours are behaving a bit more aggressively and there's sort of growth being seen in less than 6 months, that's another reason when we think, well, maybe it is worthwhile doing the scan. It might also shed light on things. And occasionally it can be done to guide a biopsy if that's necessary. And this is a way that can be used. This was a patient who had a kind of a metastatic insulinoma, so it was a tumour that had arisen in the pancreas, and doing both an FDG PET and a dotatate PET scan in this patient showed quite different behaviour at different sites, and it was able to lead to sort of a targeted biopsy and a targeted treatment to help in that particular patient's case and make a very rational way of relieving actually all of their symptoms and targeting the sites of the tumours that were making a lot of the insulin. So it's another example of that personalised medicine. And so when you do use, in those circumstances, and we use it to different degrees in different patients, the combination of those dotatate PET scans, which are more typically positive in patients with, where the tumours are of a lower grade or more slowly growing, and in patients where the tumours can be perhaps a bit more aggressive or growing faster, FDG PET scans can sometimes be more helpful. I'm not going to go into all the detail of this, but the main point is there's a variety of different treatments that are used for patients with tumours that are, different tumour grades. And so using those tests can help in some circumstances to guide biopsies and get more information about that tumour so it can be treated in a more individualised way. When it comes to peptide receptor radionuclide therapy or PRRT, the main tracer, really, the key treatment that we use is complex to lutetium-177. And what that is, all radioactive isotopes, they undergo radioactive decay in slightly different ways determined by, their physical characteristics. And so, for example, gallium-68, that's what we use for PET imaging. That emits all of its radiation in sort of very faint rays via positrons that can be picked up on a PET camera and are useful for imaging. Whereas the characteristic of lutetium-177 is it delivers most of its radiation in a really intense localised blast within about 1 millimetre. And so it happens to have quite good, radioactive characteristics that when that is bound to dotatate, it goes to the tumour in the same ways that the PET scan does, but then, when it binds to that receptor, it gets internalised into the cell and then delivers that intense radiation within about 1 millimetre and is effective treatment. This is one of the key studies that's guided the use of lutate in patients with neuroendocrine tumours. It was a big study published back in, I think, 2017, and it was a study done mainly in Europe and in the USA, and the key message, this was in patients who had tumours that were arising from the small bowel that had spread, and despite treatment with octreotide, the tumours were growing, and there was evidence that they'd grown in the preceding 3 years, and then they were randomised to either receive then the lutate treatment, or they could have they would double the dose of the octreotide. And at this stage, they weren't really sure, which would be the better test. So it's a randomised controlled trial. And the key measure was that the patients who'd had double the dose of octreotide, the tumours were growing on average. Half of them were growing about 9 months later. And the patients that got the lutate, that growth was very significantly prolonged to between sort of 30 to 40 months. And so that's sort of formed the basis of how we use lutate, for our patients. And we can extrapolate beyond that. As Mark had said, there are other smaller studies that can guide how we use lutate in tumours that can arise from different regions. But this is sort of a key study underpinning that. There was another trial. This was a trial from 2022 which showed the benefit in patients who had pancreatic neuroendocrine tumours compared to another treatment, sunitinib. Which was a small trial, but was still a positive trial and showing the benefits of lutate. And then just more recently, in fact, just earlier this year, there was another important trial, which was the follow-on to NETA-1, which is called the NETA-2 study. Not a very creative name, but it was a really, really important study because, in fact, it's actually the first randomised controlled trial that's shown the use of radioligand therapy or the whole class of treatments like lutate as the first-line treatment in any solid tumour. And so this took patients who had more higher-grade neuroendocrine tumours, so a Ki-67 over 10%, less than 55%, and it could be either small bowel nets or it was any gastroenteropancreatic net, so from the small bowel, colon, or the pancreas. And they had to have been diagnosed within the last 6 months and have no prior systemic treatments. And, importantly, that also showed significant, positive response. So in delaying the disease progression, quite significantly in that cohort of quite high-grade disease. So that's another trial that now guides the way that we treat patients. In actual fact, the principles of that trial, though, based on other smaller studies, it doesn't actually change the way that we'll do things because this is effectively how we've treated many patients anyway for several years. But it's nice, and it's nice to confirm that with that sort of a trial. So the patients who we treat with PRRT, and often, you'll see these slides, you'll hear these discussions, and then you think, well, if it's so great, why don't we just give it to everyone? And the issue is we do need to have particular criteria that are guided by those trials and all that data. And of course, as I'll go through at the end of this slide, it does have some toxicity and some risks. So it is important that through the use of looking at these trials, we know that, the benefits of that treatment, outweigh potential risks. But the key criteria are that, it's a tumour that can't be removed, it's unresectable, it can't be surgically cut out, because obviously if you can remove all of the tumour, because it's localised, that can be curative. And we need to see that on that dotatate PET scan, there's enough uptake on the scan at all the sites of disease to show that it's likely to benefit from the treatment. And we don't want to have any large sites of disease that aren't expressing those receptors or that are FDG-avid and not expressing the dotatate uptake. Because again, that would be futile and those sites of disease won't be treated and are more likely to cause the patient's symptoms. And then we either need to have the presence of, uncontrolled, despite those features, the patient needs to have, really uncontrolled significant symptoms that can't be resolved any other way. And examples of this are things like a metastatic insulinoma that can cause really severe symptoms and keep people in hospital. And in that situation, we don't need to see disease progression or other features. In its own right, we know that can be effectively treated. The most common cause is when we see there's evidence of significant disease progression. And sometimes for this decision, it's at a review at a meeting like we have every week, where to work out, like a report might say, oh, there's some disease progression, but it takes a discussion at the meeting to say, look, actually that really is above the threshold for us to treat. And then that other group, which relates to that NECA-2 trial, is those patients with high-grade disease and a large burden, in which case we don't need to have seen that progression over time. We're comfortable that because that's likely to grow quickly, to be able to treat, at that point. And so, the contraindications, there's a few reasons, I won't go into great detail, but there are some reasons why we would decide not to treat someone despite that. And one of those, I don't know if I've actually listed it there, but would be, uncorrected severe carcinoid heart disease, because patients can get into real trouble in that situation. They just don't tolerate, if they have a flare of carcinoid crisis, it can be really poorly tolerated because of reduced blood flow and return to the heart. In terms of side effects, it's generally very well tolerated, and people might just notice a bit of fatigue. There can be some discomfort, in the first few days to weeks, depending on where the tumours are, as they take up that treatment and get damaged. Just like if you sort of, bang your leg, you can get some swelling, discomfort and bruising. That can happen at some tumour sites and can cause some symptoms. There can be a flare in patients who've got functional tumours that are, causing a lot of, hormonal-related symptoms, so flushing, diarrhoea, or insulinomas or other tumours like that. There can be a flare of that for a couple of weeks, so things might get a little bit worse, and then they tend to go better, and we get a response, and they end up, then on an ongoing basis, they're much lower. But it's just something to be aware of. The main risk that we tell everyone, and the reason why we don't just treat all patients and we have these particular criteria, is because it can, in rare circumstances, in approximately, I tell patients, between about 2 to 5% of cases, so not insignificant, it can cause like a bone marrow cancer or myelodysplasia. So it's not a reason not to treat, because we know it's a very, very effective treatment, but we don't do it unless someone's, disease is causing them enough significant symptoms to warrant that. And we know from all the studies that despite that, occurring in a small fraction of people, overall the vast majority of patients have significant benefit. So at the Royal Brisbane, the approach, once patients have been, and we treat patients from all over Queensland, and so often patients will be referred, they'll see David or Mark or other members of the medical oncology team at the Royal, and we'll have a discussion at our weekly meeting. And then after that, if it's felt, look, it's at the point where this patient may be likely to benefit from lutate, then they'll get a referral to come and see our team in the nuclear medicine department. We'll review all the imaging, have a discussion about a lot of the things I've talked about today, have a consent form signed, and schedule the first treatment. And Steph, who I can see in the back, and Beck do a great job in coordinating that whole service and making sure that it runs smoothly, and often the point of contact for you as for patients if issues arise along the way. And one of the things is we withhold the somatostatin analogue if patients are on that for 3 to 4 weeks before the treatment. There's 4 cycles that are administered about 8 weeks apart. It involves a day admission, so you're in the hospital for about 5 or 6 hours. A cannula is inserted, then some amino acids are run over about 4 hours, and the next day patients come back to have a post-treatment scan, a consultation, see how you've tolerated things, and then plan the subsequent approach to treatment. And patients maintain their ongoing clinical follow-up with your own oncologist, which is important through that process. I'm just going to whip through this in the interest of time, but in terms of the next generation, where we're heading, one of the areas is somatostatin receptor antagonists. And so there is some evidence that it's like a different form of octreotide or lanreotide. It happens to bind perhaps strangely a bit more tightly despite being an antagonist. There's ongoing trials to see if this is more effective, but it's possible this may lead to more dose being able to be delivered to tumours. But again, at the moment it is still theoretical, and it's not something that's really, routinely used in practice. I think there's a lot of excitement in radionuclide therapy moving forward, looking at these alpha particles of therapy. So they deliver very high energy over just a very short path length. I talked about lutetium-177 delivering, its radiation within a millimetre, but these what's called alpha particles, they actually deliver a much, much bigger particle of energy, and like many, many times greater, and it delivers all that radiation within just a few cells. It's exceptionally targeted and very, very powerful in the radiation that it delivers. And there's two main types. There's a couple, but there's two main types that are being investigated. One is something called actinium-225, and the other one is lead-212. There's a manufacturer of lead in Queensland, and which provides a really good opportunity, for trials, and we tend to think that's actually is potentially a better option to pursue, and for a variety of reasons that are pretty technical, but it's about the half-life and the ability to actually label that effectively, and for that to remain labelled to the treatment. And there's been some really, really exciting data that's coming out. And so this is lead dotamtate, slightly different name to dotatate. It's because it needs to bind to the lead. And again, people think lead, I don't want to get injected with lead. That doesn't sound much fun. I'll get lead poisoning. But it's just a microscopic amount of lead. So that and the point of a tracer is it actually doesn't even have a physiologic effect. It's such a small amount, your body doesn't even know it's been injected with it. This was the first study that was published about 2 years ago, when it was the first time it was ever used in humans, and they were trying to find the right dose. 10 patients had the highest dose as part of the study. It was quite well tolerated, and in fact, a very large number of patients, it actually wasn't, in the final publication, it wasn't 8, it was actually about 60% of patients who had the highest dose actually had a significant response when assessed on CT scans. When you compare that to the NECA-1 study, which is that key trial, it was only about 18%. So, so it's a really significant, improvement in that kind of response. It's quite remarkable, actually. And there's a couple of different groups around the world. There's another group based out of Iowa that are developing a treatment for this, which is sort of just underway in that sort of first in human stage. We don't have results yet. This is one patient in that first trial using this dotamtate, where, they had a complete response. All of the disease went away, which is really remarkable out of just a small cohort. Now, just more recently, this is actually only in the last couple of weeks, the phase 2 trial of that dotamtate was presented over in the US at ASCO, and the key takeaways from this were that it was, quite well tolerated, and the overall response rate was nearly 2/3, so it's about 56% across the patients that have been treated with that, having that response that you could see on a CT scan, which is a significant improvement in a similar cohort of patients to the NECA-1 study, where it was only 18%. So it's really, really promising, and it's something that we're trying, our best to get access to this, to a compound such as this to be able to use in Queensland in a trial. But there is still very limited access to lead. It's not available at the moment. But so these were the results again. Overall 57% of people had that response out of 44. So we're starting to get more numbers, and it's very promising. And these patients did quite well in the relatively limited follow-up, but this is a really good kind of curve when we look at the response that people had to that treatment. So I'll leave it there, but the key point about theranostics is that if you see it, it gives you the opportunity to potentially treat it. We've talked a little bit about how we use PET imaging scans for patients, so both dotatate and FDG. Hope you've got a bit more of an understanding about what's involved in peptide receptor radionuclide therapy, as to when it's used and what's involved in the process, and then just looking ahead, that those next generation treatment options. I think it is really an exciting time, particularly with the developments with things like lead dotamtate, and how that may well be used in time as a treatment for people if lutate wasn't effective or it had recurred down the track, because we know lutate is a great treatment. This may be an option that we'll be able to use down the track, so it's something that we're pursuing. So at that point, I'll leave you there. Thank you.
Thank you, Doug. So, I'm just going to give you a whirlwind tour of what Neuroendocrine Cancer Australia is up to. Some of you possibly know a bit about us, but a lot of you might not know a lot about us. So I just thought I'd go through what we do and what we've achieved. And I just thought, we've been talking a lot about all the different aspects of treatment and everything, but just to give you an idea from the Australian Institute of Health and Welfare last year, there's 5,556 new cases of neuroendocrine cancer in the last year, and it's been going up each year. And you can just see on that graph there sort of the incidence of it compared to other cancers. So like with brain being 1,924 and pancreatic 4,506. So it is a cancer that it used to be known as a rare cancer or a less common cancer. It's not actually that. It's a misunderstood and basically forgotten cancer in a lot of ways. So the 5-year survival rate is 51%, but when we look at that 51%, it's actually looking at all the different grades, and so it's higher, sort of like the 51 is because there's the higher grade cancers of neuroendocrine that sort of change the stats, and compared to breast, which is 95%, and that it can happen in men and women equally. So these are just some of the stats that we've got together. There's 30% of patients who live 300 kilometres or more from the closest centre of excellence, so away from Brisbane. There's 25,551 plus Australians who are living with NETs in the whole of Australia. The average wait for a person to get a correct diagnosis is 5 to 7 years. So there's a 1 in 55 chance of Australians developing a neuroendocrine cancer. And then there's 1 in 2 who were originally diagnosed with something else, which is why we've got our camouflage campaign, because all those symptoms, people are misdiagnosed with other conditions. So in saying that neuroendocrine cancer is common, it's the 7th most commonly diagnosed cancer in Australia, and that's collectively, because being a neuroendocrine tumour, it can be a nearly everywhere tumour. So if we look at all the different types of neuroendocrine cancers, it comes in as the 7th most common diagnosed cancer. So 1 Australian is diagnosed with a neuroendocrine cancer every 90 minutes, and one of the stats that is one that we really didn't have, 60% of patients are at stage 4 by the time of diagnosis, which means that it's spread to other organs, and that's predominantly because of that 5 to 7 years of waiting to get a correct diagnosis. So neuroendocrine cancer, our vision is to be champions of early diagnosis and a cure, and our mission is to assist and support patients and carers through support groups and access to networks of expertise, and we work very closely with all the centres of excellence around Australia. We also want to lobby for access to new and appropriate investigations and treatments, and we have been quite active with that recently, and I'll go into that in a little bit more detail. We want to raise awareness and knowledge with the medical community and the general public, and we also want to encourage and support research in the area of neuroendocrine cancer. So we are very actively involved with the Planet Registry. It's been a bit slow in taking off, but we hope that we can continue the momentum and sort of get it happening more. So that's at each of the centres of excellence around Australia, and every person who is diagnosed with a neuroendocrine cancer would be in that registry, so that we can keep a really good tally on what's happening, where the cancers are located around Australia, what types they are. And then David has talked about the AUSNET nurse-led shared care model. So one of our main things is patient support. So we have our NET Nurse Support Helpline, of which Dana's one of the nurses. And on average, we're receiving over 200 contacts a month. And this number's been going up by about 25% each year. So Dana is full-time. She's been funded by anonymous philanthropist, and we have 2 other nurses who are working job share, and that again is actually funded by patients. So we have our patients, you, who are funding what we're providing. So we just really, well, we're about to have some good news from the government. So yeah, stay tuned. We'll let you know in the next newsletter. So with the resources that we've got, we've done 3 explainer videos, and the last one that we did was PRRT, which is now available on our website, and we're just about completing one on familial neuroendocrine tumours or hereditary ones. We have support groups across Australia face-to-face, and that's with local groups where we have the numbers for people to attend. And we also do national Zoom meetings monthly, and we've just started doing a carers support group as well. And the private Facebook discussion group has over 2,000 very active members, which is a great forum for everybody to learn from each other, share stories, and it's also moderated by patients, but we also have our staff who keep a close eye so that they can actually sort of assist on a one-to-one basis where needed. And NECA remains the main referral service for NET patients around the country, and a lot of those do come through from the Cancer Council as well. So just with research, these are areas that we are very active in. So as I said, Planet Registry, the AUSNET nurse-led shared care. We also treatment in the community, which was a study that we were doing with Ipsen. There's a menopause study that we're doing with Melbourne Uni, which we were really grateful to be asked to be part of, because nobody's really looked at menopause in neuroendocrine cancer patients, whether it's menopause because they're going through menopause, or whether they're menopause symptoms because they've got neuroendocrine cancer. So it's ongoing, and we're keen to see what the results are. We're also actively working on a nutrition screening tool with Erin Lang, who is one of the main dietitians down in Petamac, and we're hoping to get this screening tool happening, and that'll be actually multi-country, so New Zealand, I think the UK, North America and Canada. There's a lot of genomic studies that are going around at the moment, and we've been asked to be associate investigators in those. There's also a PET study that David Chan in Royal North Shore is hoping to get off the ground, and I've got down the bottom there, funding government apology, because for years we were getting letters back from Greg Hunt's office and also Mark Butler saying that $73 million had been given to neuroendocrine cancer for research. And we thought, sorry, where is that happening? And I know we spoke to all the clinicians and said, are you hiding any money? And, you know, where's it? Where are you using that money? Anyway, it ended up that we did a lot of investigating, and we found out that a lot of the studies that were being done and funded through NH&MRC, they had put down, I think $8,000 were neuroendocrine tumour. They sent me the spreadsheet, and I looked down the bottom and it said neurological cancers. So it was brain. So that 60 odd million was going to brain, but they had it put down as us. So we did get an apology from the government and also from NH&MRC, and since then we're watching everything very carefully to make sure that their numbers add up. I'll zip past this one. And just a little bit about the Planet Registry. It does have an app which also can do quality of life, the Bristol Stool Scale, weekly vitals and performance status. And the patients who are actually using the app, we're getting a lot of really good information. So, and it actually is very helpful to have in the consult, so that they're recording everything that's happening, it graphs it, and then when the consults are happening, you can actually show what's happening. Education, we've got some of the flyers out there. So how to identify neuroendocrine cancer when it's not part of the typical lineup. So we did the education modules, which we launched World Net Cancer Day 2021. We've had over 3,981 healthcare professionals complete those, and some of those are nurses as well. But we continue to push them out, and we're still getting a good response with GPs attending and doing the course. Last year we got a one-off national awareness campaign from the government, so that funding's just stopped, and we did the camouflage awareness so that we could get people out there knowing about the symptoms. And we actually have had quite a few patients who have rung us up because they've heard about us now, where they hadn't heard about us, had the symptoms and said, what should I do to go to the GP? So the nurses have been able to send through the Optimal Care Pathway Quick Reference Guide for GPs, taken those to their doctors, and they've been able to then know what tests to order. A lot of people have tests ordered that might not be necessary, but with this they've been able to have those, and we've had quite a few of those patients come back and say that they actually have been diagnosed with a neuroendocrine cancer. So we really want to just keep the momentum going with that. We've also got Project Officer Nurse Educator who does in-services online, and they're all free. And we have a NET patient education program, which is called Living with NETs, which we started in October 2022, and we do 3 courses of those a year. They're online. They're for 2 hours each, and it's for 4 weeks, and it goes through everything sort of from learning about neuroendocrine tumours, treatments, living with NETs, and a lot of other helpful information. We also do a lot of conference presentations, and on this week we've got Cancer Nurses Society of Australia, and we've got 2 podium presentations to talk about some of the studies that we've done. We're also hoping to get some dietitian education modules happening, and NET patient forums, we're back doing those. So this year we're doing Brisbane, Canberra, Melbourne and Sydney. And last year we did Perth, Adelaide and Launceston. So we want to keep the information out there and give you the opportunity to be here and be able to ask questions of the specialists that are here. So we have a national action plan, which at the moment we're just in the process of doing a supplement to update that, and ongoing meetings with MPs, and the Optimal Care Pathway, as I just mentioned, has been launched. Other advocacy, we did the Senate inquiry submission, and we presented at the Senate inquiry, and that report has come out, and there were 41 recommendations, 31 of which are applicable to neuroendocrine cancer. So we're going to be lobbying the MPs to see what the government's going to do to actually fulfil the recommendations made by the Senate. We do a lot of consultations and submissions for MSAC, so Medicare. We've also been doing a lot of work with the von Hippel-Lindau community, and we did a petition through the House of Representatives and got 17,803 signatures. And at the moment, I got an email today from the senior advisor for Minister Butler that it's on his desk and waiting to be signed with his recommendations. So it will be interesting to see what comes out of that. So with all this, belzutifan is a drug that is beneficial for patients with von Hippel-Lindau. It's not available on the PBS yet. We've got one patient in Australia who's paying $12,000 a month for the tablet, so that it does control the growths and reduces the impact on surgery. So we're doing a von Hippel-Lindau parliamentary event on the 4th of July and got a lot of MPs coming to that, so that we can hopefully get the PBS approval fast-tracked, because at the moment I think it's 446 days or 422 days from when a drug is approved to when it's available, which is not satisfactory for anybody. Getting lots of patient stories and interviews, and putting those on the website, which people have found to be fabulous. I'll zip past that one. Just a little update on somatostatin analogues. The eShine program closed on the 30th of April, but there is still training available for GPs and other healthcare professionals if they need to be trained up to do the sandostatin LAR injections. Ipsen still has a home injection program, and there's a generic lanreotide which was made available August 2023, but that doesn't have a home injection program. But we do work very closely with all the organisation or the pharmaceutical companies to ensure that patients are able to get their injections and get them administered correctly. So this is one of our patients down in Melbourne who put this together for a presentation, and he said, this is our unicorn combi, and it's like you have to drive your own bus. So we want to help you to advocate. You can let who you want in and out of your bus, but that's your bus to drive. So we're here to help, and thanks for listening to me. So I'll now open up for questions and answers. Can I get you to talk into?
Thank you. Is it on? Yes. It is. This is for Dr. Pattison. Are we getting a copper scan?
We're getting a copper scan here.
Yeah.
We don't have one yet. There's not any. There's not any imminent plans to have one here. Sorry. I think that there's no kind of clear evidence that it's sort of broadly better than so a dotatate PET scan that we've got is very, very good. I think there's a few sort of niche elements where copper imaging can be helpful, but it's pretty rare where there's actually a difference. I was in which way? Yeah, I don't think it's that much quicker. No, so it's one of those things. I was actually involved in the first actual trial with copper down at Peter Mac, and it was there were some very rare circumstances where it could be helpful. I think it would be a great thing to have to do particularly for some dosimetry studies and research. But I think in terms of for the day-to-day patient experience, I don't think it's something that we. Well, I mean, it'd be great to be able to do absolutely everything, but I think it's it's an innovation. But I think a dotatate PET scan covers probably 95 or more. Is it? Oh, so we could use it in. There's one particular trial that I think would be really nice to do with that in a broad level. So look, it would be good, but we don't have access to it at the moment. I know there is an ongoing study down at Peter Mac where they're looking at it, and that's where they've got that link in a research setting. So if there was an opportunity to join in a trial, we certainly would, but we just don't have an opportunity now. But to be honest, with the dotatate PETs, and one of the key things that we're working at is even the other aspect of that is the technology. So the PET scanner, and certainly at the Royal we've got a very good quality PET scanner now, which is very fast, and we're actually we've spent about 18 months to lobby to try to get kind of the absolute latest, like a whole body PET scanner, which from a patient perspective would make a significant difference because it's much, much quicker, and much, much quicker than anything that that copper would do. It's really, really very fast.
Thank you.
No worries.
Any other? Yes.
This might sound like a silly question, but I'm not an expert. Does it matter which MRI, if it's an older MRI scanner or a newer one, is there a difference in the imaging? Should you always go to the same place for an MRI to check on measurements? And I don't know who could answer.
We can answer that one.
Sorry.
Look, in general, as a principle, it's a good idea to go to the same place because then that they'll definitely have the previous imaging available, which is the most important thing for the comparison. And I think generally the vast majority of MRI scanners will do what you need them to do in terms of giving a reliable measurement. And I think that the most important thing is actually going back to that same place because it's being measured on the same machine, you want the same comparison. If you did go somewhere else and it was even higher resolution, it's not necessarily going to be beneficial, and they may actually, the measurements might not be done the same way. Yeah, so I think that's...
I've got a question which is medical oncology posed, but you didn't mention it. That's just come into my head. Zemelo, would you... I know it's only been available on a compassionate scheme in Australia. It's a medication to reduce diarrhoea for carcinoid. From your opinion, would it be good to have access?
I guess the answer is yes, but probably for only a small percentage of patients. Because I guess the best way of reducing carcinoid syndrome-related symptoms is to control the tumour. And so before we had really effective PRRT, it was probably more of an issue with patients who we couldn't control symptoms. But now with SSAs, but particularly with PRRT and other systemic treatments, the number of people who have really severe symptoms is pretty low, and it's usually related, ones I can remember more recently, have been people whose tumours are progressing despite treatment, and that's a very difficult situation. When it was on the compassionate access, we did use it for some of those patients, and I think my experience is if your tumour was relatively stable, some people got benefit, but a lot of people whose tumours were progressing, really, it wasn't enough to benefit them. So I think, yes, it would be nice, but for a select group of patients, really. And treating the tumours still the best option to improve symptoms.
I'd say the same as David was saying. We're doing more and more retreatments now, more and more experience with that, and it's certainly one of the criteria we look at. Importantly, is what symptoms people are getting. We don't just look at as someone progressing on a scan. We look into, what symptoms is the patient getting, and therefore what benefit might they get from that treatment. So I think commonly something we look at is if they do have carcinoid syndrome and that's getting worse, sometimes that can be a sign that we'll retreat. Or insulinomas, like you said, we know that their symptoms will get worse because their blood sugars will, drop. But yeah, I think we're using more and more retreatment rather than, that particular medication. As Dr. Wyld said, it'd be nice to have for the group of patients that perhaps may not be, lutate unfortunately sometimes doesn't work as well as we'd like. So if there was a treatment available that might control people's symptoms from from that perspective, that would be good to have. But understand funding issues, and it's expensive medication too. So, yeah.
Slightly off track from that. I think certainly the people who see a lot of NETs are much more conscious of other causes of diarrhoea now. So be it short bowel or pancreatic insufficiency is probably something that wasn't picked up as well in the past. And I think people are much more likely to give a trial of Creon or other things, things for short bowel, which can make a huge difference to people which may have missed a little bit in the past.
Lorcan, you mentioned pro-BNP. Is there, I know it's not on Medicare, is it worthwhile sort of pushing for that to be on Medicare as opposed to sort of then having to have echoes and things that it could be easier to detect?
So the BNP is what we call a biomarker. So it's a blood test, and it's something that is released from the heart when it's under strain. So and that could be for many different reasons. And it's a blood test that's commonly used in cardiology to diagnose a wide variety of conditions. So it would be nice to see it on the covered as a blood test on the PBS for a broad range of reasons beyond just helping to diagnose carcinoid heart disease. It has been shown to be useful in not necessarily diagnosing carcinoid heart disease, but identifying those patients who certainly could be at risk of having significant valve dysfunction, and it could also be a good rule out test as well. So rather than going through an echocardiogram, not that that's a big deal at all, but if this BNP blood test is performed and it's normal, it's negative, that is pretty good evidence that pretty good evidence that the risk of carcinoid heart disease is much lower. It could be useful.
Thank you. Any other questions? Here's your opportunity.
Just recently on Facebook Net, there was a survey done on different lanreotide injections.
Yeah, octreotide, there's two octreotide and there's two
Yes.
One of each is generic.
Okay. The one beginning with M,
Yep.
whatever that is.
Generic lanreotide.
Yes. Yeah, so there's a little survey on there, and I've just noticed I've had 4 injections. I'm going to find out from my oncologist what the first one was. No symptoms, and the next 3 were at the 3-week. Lots of swelling and nausea and vomiting, so.
Good thing to discuss with your oncologist.
But I had no idea until I looked on that. I thought I was getting food poisoning or something. I've got to watch my diet. No.
Just going back to the injection, with the, is it the lanreotide? Yeah, and the generic brand, is there a difference, a big difference?
Who knows that was the way they used the compound?
Yeah, because on this talk on the group chat where David's only used the lanreotide, his symptoms have been quite high, yeah, very different. So we're just wondering, would the other one, if we tried that, make a difference necessarily? Is that the one you were talking about, starting with the S?
Did you want to say anything? Or?
I think all we can say is that
Yep.
the generics are biochemically similar to the original. I think, and I'm the nursing team are probably better, but there's a different injection mechanism. So some patients are going to find that better or worse in terms of the delivery of the drug. I think in the past we have occasionally switched patients from one type to another, but it's completely anecdotal to see if they feel that maybe they feel better on one versus the other, which in the past was lanreotide and not. But I don't think there's any evidence to.
And the one we just spoke about, starting with the S, is that... Yeah.
Octreotide.
Yeah. So is that what they use for the lunch? Starting with
They're both somatostatin analogues. So one is octreotide, the other one is lanreotide. So they are slightly different.
They're used for the same?
Yes.
Okay.
And some people tolerate one better than
Yeah,
the
that's
other.
what I'm thinking. Yeah. We're very, very new to this. Yeah, it's only 3 months in, so it's a lot to take in. But yeah, very much so. But the side effects have been quite unbearable.
Definitely talk to your oncologist
Yeah.
or prescribing doctor.
Yeah.
Once you've got a mix.
Sandostatin LAR is a deep IM, whereas the lanreotide is a deep subcut. Yeah.
Yeah.
And they're both butt harpoons. Yeah.
Yeah, and the ones they're both given in the same place. Like,
That's the lanreotide. Yeah. It's a bit hard to.
yeah,
The lanreotide for both generic and generic refill syringe.
Yeah. okay.
Yeah, there can be some side effects from this as well. Also, it's insufficiency, so sometimes people get
We've tried that, and that's not subsiding, is it, at all?
So the first injection was pretty bad, got the crayon, the second injection was great, the third one was back to disaster again. Yeah, so I'm not sure what's going on.
There can be some options.
Yeah. But we're still collating all that information just to see. I mean, yeah, everybody's very different.
Excellent.
Yeah. So, yeah, you can't really sort of
Yeah.
say anything hard and fast.
Yeah.
Yeah. Any other questions?
The valve, like, is AF got anything? How does that affect it at all?
Yeah. So AF being atrial fibrillation, so an irregular heart rhythm, which is something that's very common in a lot of different patients, even young and older patients. It's not something that would have a significant effect on the overall condition of the heart itself directly, but what we could probably say is that if you do have changes consistent with carcinoid heart disease, you probably are at higher risk of developing atrial fibrillation just because those top chambers of your heart are under a bit more strain. That's the area that the AF comes from. So it doesn't affect the carcinoid changes itself, but if anything, could be a result of them. So and the symptoms to watch out for there: racing heart, again breathlessness, chest discomfort. Yeah.
So in AF before, I realised NETs, but whatever medication I was on, I'm off all that now. Since the NETs, because the heart rate was so low with the solitol and stuff like that. So yeah, I just was wondering, was it actually AF that I had, or was it something else?
Yeah.
Heart racing is one of them. That was probably the only real thing I had. Fatigue was another thing I had. I lost taste and smell for a while, but I actually was told it was from all over.
I think probably that's a good example of some of the difficulty in the interplay between this condition, diagnosing it, differentiating it from other conditions, and then the interplay between the treatments itself. Because you mentioned the sotalol treatment there, which is a treatment for atrial fibrillation to slow the heart rate down. That itself can cause fatigue, just as the AF could, just as a neuroendocrine tumour could. Yeah, so it's difficult, but it's not uncommon for. It's very unusual for a patient to only have literally one condition. So it's a common thing we have to deal with all the time. Patients with a lot of different conditions and managing all of that. Yeah.
Sorry. So in David's case, should he have that test for the? Is it the echo?
Well, I think if you.
No, that was more advanced.
I think if you've had a history of atrial fibrillation, the chances are you've had an echocardiogram before. And I don't think the recommendations about when to do what tests would necessarily be that different for you, just given that history. Yeah.
Okay. Last one. But you have to have the talking stick.
I just want to ask a quick question about the cancer genetics of neuroendocrine cancer. My sister passed away last year with lung carcinoma that spread to her liver, and I was diagnosed in October last year. And I have appointments with the Genetic Health Queensland for next week. But I'm just looking for our children and grandchildren, what your thoughts are on the possibility that it's passed down through families. I don't know who can answer that one.
There are some syndromes associated with some specific types of neuroendocrine tumours. There's a couple of things. Syndrome called an MEN. It's called multiple endocrine neoplasia. Often ends up with medullary thyroid cancers and sometimes pancreatic neuroendocrine tumours as well. And that's certainly something that's passed down with a genetic link. Other neuroendocrine tumours, for the most part, for a majority of people, they occur sporadically, and there's no clear familial link. With the increasing availability, though, of genetic testing now, if we are seeing some patients who have got a strong family history, perhaps suggestive of some sort of familial link, we will refer to Genetics Health Queensland because they're consistently developing new panels to look for certain genetic links in families. and there's only some that we know about, and certainly some will come out in the future. So if there is a strong family history, we'll, for the most part, refer or advise people to see a genetic counsellor. But it's, for most people, it's you know, cancer, very, very common in Australia, and it's most likely for most people that it's just a sporadic cause in both people rather than genetic link. That's probably the more rare situation.
Okay, thank you so much, and thank you so much to our guest presenters tonight. They've been fabulous topics and sort of covered a lot of different things. So thank you for coming, and we'll be back again in 2 years' time, and keep your thinking caps on as to what you would like presented at the next one. But appreciate you coming, and just reach out to us if we can do anything. But if you can put your hands together for our guest speakers.